Hello, my name is Natalie Chaser, and I will be speaking to you about chronic lymphocytic or Hashimoto thyroiditis. The case study is as followed. A 38-year-old attorney reported for her yearly physical examination complaining of tiredness, difficulty concentrating on her work, and a noticeable decline in her memory over the past several months. She attributed many of these symptoms to the severe stress generated by her legal caseload. Further questioning by her physician revealed that the frequency of her bowel movements had decreased from once daily 6 months ago to once every 2 or 3 days. She was having difficulty avoiding gaining weight, and despite warm weather, she felt chilled with a light sweater. Her only medication was an oral contraceptive. Physical examination revealed a well-proportioned woman 65 inches or 1.65 meters tall, weighing 125 pounds or 56.7 kilograms. Physical examination also reveals sparse eyebrows, particularly at the lateral margins, and a diffusely moderately enlarged thyroid gland with a prominent pyramidal lobe above the isthmus. The laboratory values were as follows. T4 total was 5.5 with a reference value of 5 to 11.5, which is a normal range. T4 free, which is 0.25 value, which reference value is 0.76 to 1.8, which is decreased in levels. TSH value was 22, and the reference value is 0.4 to 4.5, which had a significant increase. The anti-thyroid globulin antibodies was positive, which the reference value is negative, and antimicrosomal antibodies was positive, where the reference value was negative. A fine needle aspiration of the pyramidal lobe revealed lymphocytes, plasma cells, and cohesive clusters of enlarged follicular cells with nuclei and abundant eosinophilic granular cytoplasm, which is called Hürthle cells. The patient was placed on medication and asked to come for a follow-up. A synopsis of Hashimoto thyroiditis. Thyroiditis is the inflammation of the thyroid gland. There are 3 types: Hashimoto thyroiditis, granulomatosis thyroiditis, and subacute lymphocytic thyroiditis. The one we'll be speaking about is Hashimoto thyroiditis. It is one of the most common causes of hypothyroidism and is most often found where iodine levels are sufficient. It is caused by a gradual failure of the thyroid gland, and which is secondary to an autoimmune destruction of the thyroid glands. It's most commonly found in and diagnosed in older women, usually between the ages of 45 to 65 years old, and is most commonly found in women over men. It can occur in children and is a major cause of non-endemic goiter in kids. The cause of Hashimoto thyroiditis is the breakdown of a self-tolerance to the thyroid autoantigens. The antibodies against the thyroid antigens causes a large depletion of the thyroid epithelial cells or the thyrocytes. These thyrocytes, when they're destroyed, are replaced by mononuclear cell infiltrates and fibrosis. Researchers have found that there are multiple immunological mechanisms that help with the destruction and damage of the thyrocytes, which include a CD8+ cytotoxic T-cell mediated cell death. Second is a cytokine-mediated cell death, and the third is the binding of anti-thyroid antibodies, which goes into antibody-dependent cell-mediated cytotoxicity. Researchers also have found a genetic component in twins. About 40% of twins are found to have this, and they also found that in about 50% of asymptomatic siblings that have a sibling that's affected or a person that they know is affected has anti-thyroid antibodies. Most oftenly, there's an increased risk when they find that there's a polymorphism in multiple immune regulation associated genes. The most common linkage is to cytotoxic T lymphocyte associated antigen 4 gene, which codes for a negative regulatory of T cell function. When you have a disruption of thyroid follicles, which help make a large release of thyroid hormones, there is an increase in free T4 and T3 cells levels, and the level of the TSH is decreased, and the radioactive iodine uptake is decreased. When hypothyroidism supersedes, there is a decrease in the T4 and T3 levels and a large increase in TSH levels, which you saw in the case study. Most common way to identify this autoimmune disease, Hashimoto thyroiditis, is when you see a diffuse and symmetrical enlargement of the thyroid gland. There are some cases that show a localized enlargement, but when you look at the thyroid gland microscopically, there's a widespread infiltration of mononuclear inflammation that contain lymphocytes, plasma cells, and germinal cells. The follicles in the thyroid gland show that they're atrophic, and they're lined by epithelial cells that contain eosinophilic granular cytoplasms, which are also called Hurth cells. Most oftenly, Hashimoto thyroiditis is just a painless enlargement of the gland, and over time, this also causes hypothyroidism. Hashimoto thyroiditis is also largely linked to an increased risk for development of B-cell non-Hodgkin lymphoma, and also some studies and research have suggested that there is a large correlation with Hashimoto thyroiditis to papillary carcinomas in patients. The first article I chose to talk about Hashimoto thyroiditis is the evaluation of endothelin 1 and endothelin receptor type A, or eDNRA, gene polymorphism in Hashimoto thyroiditis. Endothelin 1 is a marker of inflammation, and the activity of the endothelin 1 is mediated by the endothelin receptor type A. It has been established by researchers from the article stating that the role of chronic inflammation and endothelial dysfunction has been noted in patients with Hashimoto thyroiditis. The study done in this article was of 163 patients with a diagnosis of Hashimoto thyroiditis and a control group of 181 individuals that had no personal or family history of a thyroid disease, and any patients with any comorbidities like cardiac issues, autoimmune disorders, infections, or musculoskeletal or any malignant diseases or any kind of trauma or operations recently were excluded from the control group. The study was done to find if there was a possible association of the endothelin 1 gene and the endothelin receptor type A gene with the occurrence of Hashimoto thyroiditis, and to evaluate the relationship of the genotypes with any manifestations of this autoimmune disorder. Endothelins are vasoactive peptides that are known to be found by researchers in the inflammatory process. 3 isopeptides were identified, which is endothelium 1, 2, and 3. And there were also 21 amino acid peptides that were found to be important vasoconstrictors. The article mentioned that Hashimoto thyroiditis is one of the most common organ-specific autoimmune disorders affecting, they said, about approximately 18% of the population. A characteristic of this type of disease is infiltrates of the thyroid glands, such as lymphocytes and plasma cells, and that there was an elevated levels of serum anti-thyroid antibodies, and that the enlargement of the glands, and that there's frequently thyroid dysfunction with these patients that can correlate into relation later with hypothyroidism. The exact pathophysiology mentioned by the researchers in the article is not fully understood, and they still don't have a full understanding of the mechanisms of Hashimoto thyroiditis. So Hashimoto is one of the most common endocrine disorders with many different factors that could cause. They were trying to find that there's a central role in Hashimoto, and they link it to chronic inflammation, endothelium dysfunction. With the research done on these patients, they found that there was no significant difference associations between the acceptability of Hashimoto thyroiditis with the endothelium 1 as well as with the endothelium receptor type A, Synopsis. But the researchers did find that endothelium receptor type A positive 7D polymorphism was related with decreased risk for early onset Hashimoto thyroiditis. So overall, right now there's still no significant correlation, but they did find that with this research that there is that gene, the endothelium receptor type A positive 7D polymorphism, did help decrease risk of a patient having any early onsets of Hashimoto thyroiditis. The second article chosen is titled Hashimoto's Thyroiditis is associated with papillary thyroid carcinoma, the role of TSH and of treatment with L-thyroxine. The reason I chose this article was it was interesting from reading in the textbook about how there's controversy of the correlation between Hashimoto thyroiditis and the increased risk for papillary thyroid carcinoma. The research article, the study done was on 13,738 patients. 9,824 of those patients were treated, and the other 3,914 were undertreated with L-thyroxine for a goiter or for hypothyroidism. The research article mentioned that Hashimoto's thyroiditis is most commonly diagnosed in females and is most common cause of hypothyroidism in areas of the world that have sufficient amount of iodine in the dietary, and that there's an increase in susceptibility for older people. It goes in with the article talking about how the characteristics of Hashimoto thyroiditis is the lymphocytic infiltration of the thyroid gland and the increase in the thyroid autoantibodies circulating, and the cause of having a patient having spontaneous hypothyroidism. The study took the patients that 1,593 had nodular Hashimoto thyroiditis with either a high titer of thyroid autoantibodies and or hypoparathyroidism, and the rest of the patients with nodular goiters were put into 8,812 were put into a category of thyroid antibodies, and nodular goiters with undetectable thyroid autoantibodies, and the other group was of 3,395 of thyroid antibodies with nodular goiters that were positive for the thyroid autoantibodies. The research from this found that patients that had nodular Hashimoto thyroiditis compared to patients with non-autoimmune nodular goiters had an increased risk for developing papillary thyroid carcinoma, and also patients with increased TSH levels also had a significant increase in the risk for the carcinoma due to the destruction of the tissues and the functioning of that the thyroid gland by the autoimmune responses developed. Also, they noticed that treatment with the L-thyroxine that helped reduce the TSH levels also helped to decrease the frequency of patients developing papillary thyroid carcinomas in patients with nodular Hashimoto thyroiditis. And with the decrease in the THS levels, slow down the cancer progression, reducing the frequency of clinically detectable cancer, researchers have stated from the studies. Researchers indicated that further studies need to be done to pinpoint the involvement of THS in indication of mutation that are developed within patients that are that develop papillary thyroid carcinomas. The reason for the further studies into wanting to find out about the mutations that might be involved with TSH and the papillary thyroid carcinomas, because papillary thyroid carcinomas are found to have a genetic alterations such as mutations, such as point mutations in the BRAF gene and the RET-PTC rearrangements in most patients that have this type of tumor. So researchers are hoping to find more significant an increased level of knowledge about the involvement of the levels of THS and Hashimoto thyroiditis with the development of papillary thyroid carcinomas.
Hi, Natalie. Just to add some information regarding to Hashimoto's thyroiditis and its association with papillary thyroid carcinoma, I came across an article titled Thyroglobulin Antibodies Could Be a Potential Predictor Marker for Papillary Thyroid Carcinoma by Vasilidis and his co-authors. And in this article, it mentions that the relationship between thyroid autoimmunity and cancer remains controversial. However, they mentioned that Hashimoto thyroiditis is associated with an increased risk of 29% developing in papillary thyroid carcinoma. Female patients with Hashimoto's thyroiditis undergoing thyroidectomy are 30% more likely to have PTC or papillary thyroid carcinoma. The prevalence of PTC in Hashimoto's was threefold increase compared with that of non-Hashimoto's. Furthermore, the spread of the PTC to compartment of six lymph nodes occur 4 times more frequently in Hashimoto's than in non-Hashimoto's thyroiditis patients. On the other hand, lymphocytic infiltration, which is an cytological characteristic of Hashimoto's, often is associated with the papillary thyroid carcinoma in the absence of the typical features of Hashimoto thyroiditis. So a possible link between the Hashimoto thyroiditis and PTC was suggested after the observation that RET genes and PTC rearrangement, which is observed in the papillary thyroid carcinoma.
Hello, Natalie. This was a very interesting article that you had on Hashimoto's thyroiditis. This is Allison. Um, I read an article that spoke about the risk of depression, chronic morbidities, and L-thyroxine treatment in Hashimoto thyroiditis in Taiwan. It was a nationwide cohort study. It was a retroactive nationwide cohort study, and they retrieved the data from the longitudinal health insurance database 2000. And they collected data from 1,220 patients with Hashimoto thyroiditis and 4,880 patients without Hashimoto's thyroiditis for the period of 11 years from 2000 to 2011. And so what they found, as you discussed, is, oh, sorry, this article was published in June 2015. As you found, there is an increased risk of papillary cancer with Hashimoto's. And what they found is that Hashimoto's can cause other chronic morbidities, which increase the risk for depression. And these morbidities that they had a higher prevalence of was diabetes mellitus, hyperlipidemia, and coronary artery disease. Ultimately, what this article found is that patients who had Hashimoto's demonstrated a higher prevalence of diabetes mellitus, hyperlipidemia, and coronary artery disease, had an increased risk of depression, and they were more depressed than the group that did not have Hashimoto's. And there had also a group, I forgot to mention, that was treated with L-thyroxine. They found that younger patients exhibited a higher overall incidence of depression compared to other patients. L-thyroxine treatment can reduce the risk of depression. So not only are they dealing with the hypothyroidism, which in itself, because it is decreasing, it's slowing everything down, there's an increased risk of depression there. And then you have these other chronic morbidities that are, I guess, perpetuated by the Hashimoto's, which also are all morbidities that naturally cause depression. Then you have the concern of the papillary cancer. So while we are focused on these patients physically, we also have to remember to worry about their psychological state, especially with the young lady that you did the case study on. She was an attorney and very busy, and she had these physical changes, but also we have to educate patients on being aware of any psychological changes that can occur, because it can be treated. In some of these clients, the L-thyroxine treatment helped. Maybe L-thyroxine and an antidepressant for some other individuals, because as we know, how a person is doing psychologically can greatly affect their their physical status and how well they heal.
The third article chosen is titled Hashimoto Thyroiditis Clinical and Diagnostic Criteria. The article goes into talking about how Hashimoto thyroiditis is one of the most common autoimmune diseases in the world. It most commonly is associated and diagnosed in women. Researchers have found that there are clinical pathological variants such as fibrous variant, IgG4-related variant, a juvenile form of Hashimoto thyroiditis, Hashimoto thyroiditis, and a painless thyroiditis, or sporadic or after postpartum. Each of these variant forms are associated with the infiltration of lymphocytes within the interstitium around the thyroid follicles. And each of these variants can also have a specific feature to each one of these. Over time, the thyroid cells become either atrophy or transform into a mitochondrial-rich cell called Hth cells. Most oftenly, Hashimoto thyroiditis is involved with the evolution of patients developing hypothyroidism. A diagnostic criteria for these types of patients is the circulation of antibodies to the thyroid antigens. Mostly commonly are the thyroid peroxidase and the thyroglobulin. Researchers have found that this type of autoimmune disorder, it can be classified into primary and secondary. Primary is the most common form, and it comprises of those that do not currently have identifiable cases of why it was developed. And research has found that with primary Hashimoto thyroiditis, there is a 0.5 to 30% of most cases are associated with papillary thyroid cancers. Secondary form is when the agent can be clearly identified, and it's most commonly associated, it can be with like hepatitis C infection, use of interferon alpha for with CTLA-4 blocking antibody for solid tumors, and cancer vaccines. The primary form is associated with like isolated with the variants of classic form, the fibrous variant, the IgG4 related variant, the juvenile form, the hashimotothyosis variant, and the painless thyroiditis, which is shown to be in sporadic or postpartum, and is also associated with other thyroid diseases like papillary thyroid cancer and other autoimmune diseases. Hashimoto thyroiditis was first described in Japan in 1912 by Dr. Hashimoto, and now this disease has come most frequently, and its incidence is 1 case per 1,000 persons per year, and is more likely in women than in men, 8 times, the researchers have found, and is more common in whites and Asians than African Americans. They also found that smoking and iodine are 2 environmental factors that have been studied in relation to Hashimoto thyroiditis, and actually research has found that smoking has a beneficial factor on Hashimoto thyroiditis. That the research has found that tobacco smoking actually decreases the level of thyroid autoantibodies, as well as helping to decrease the risk of hypothyroidism. However, right now, the mechanism why the smoking has such an effect, and a beneficial effect on Hashimoto is still being researched. And the increased levels of dietary iodine found in patients is actually highly associated why there's more cases of Hashimoto thyroiditis. The diagnosis of Hashimoto thyroiditis is currently done in combination of any clinical symptoms or signs, the presence of serum antibodies against the thyroid antigens like thyroxine peroxide and thyroglobulin, and the appearance on thyroid sonograms. Right now, rarely used is the thyroid uptake of radioactive iodine and cytological examination of the thyroid by aspirate. They have found that there are so many manifestations associated with Hashimoto thyroiditis within many different organs, areas of the body. Like the GI tract is most commonly found with constipation and things like that. With the skin, their skin is more dry, cold, and yellowish, and their hair starts to become coarse or falls out. The cardiac system, they start to have bradycardia, and they have a decreased ventricular contractility and increased peripheral resistance, which overall reduces the cardiac output. Most patients may present with cardiomegaly and pericardial effusions. Coronary artery disease is common in patients with hypothyroidism. And skeletal muscles, they start to have hypertrophic due to the myoechymosis infiltration in the tissues, and so it causes like pain and cramps in these patients. Their pulmonary system also is affected by having bradypnea and hypoxia. By they might have pleural effusions, and some could go into respiratory failure due to comas. Also, they can be anemic. Their reproductive system, they could have abnormal menstrual periods, which also hypothyroidism during a pregnancy could cause an increase in miscarriages, and the urinary system could cause urinary retention due to decrease in glomerular filtration, and neuropsychiatric system, they start to have an inability to concentrate, memory loss, and depression is noted in patients with Hashimoto thyroiditis. And also, there's still controversial issue. They're still trying to link Hashimoto thyroiditis to encephalopathy in patients. Currently, researchers in the article state that treatments are done by symptoms, signs, and symptoms that these patients present with, and that it's just a medical disease, and that patients that do have thyroidectomies, most oftenly it's due to if they have any signs of any severe cervical compressions, or for if the patient feels that they cosmetically need it done, or if the nodule is suspicious of being a carcinoma or having any kind of cancer relation. Right now, the only treatment is thyroxine medications like levothyroxine for hypothyroidism to help with the function of the thyroid gland. And also, they mention in the article about the use of glucocorticoids for patients. Right now, they're also trying to find dietary ways to help prevent and treat patients with the development of this disease, and they're hoping with further knowledge and expansion on the disease and the pathogenesis, they can find more ways to prevent or treat and find new ways to treat this disease to help patients in the future. All three articles mentioned were helpful in learning a deeper understanding of Hashimoto thyroiditis, about the pathophysiology, which is still under a lot of research. The researchers are trying to get a better understanding of the full scope of the pathophysiology of this autoimmune disorder, understanding the genetic linkage that they're starting to find with this autoimmune. Also, the treatments, like with hypothyroidism, leaving thyroid medications, but also mentioning that they treat the symptoms and signs that the patients present with, and having an understanding the diagnostic criteria used to diagnose these patients with Hashimoto thyroiditis, and the characteristics assigned to the disease, and how these patients also have a increased risk for developing certain types of carcinomas like non-Hodgkin's lymphoma, and now the researchers are finding a link, like mentioned in the article, with papillary carcinomas, and understanding the mechanisms behind the autoimmune disorder and the inflammatory processes, and just having a deeper knowledge that researchers are hoping with more research and more continuing understanding that they can find a better ways to treat these patients and to help manage the disease, or maybe even prevent further complications and comorbidities, and understanding the variants in the different types, like mentioned, like having the juvenile form of Hashimoto thyroiditis or the fibrous variant, and many other ones that were mentioned in one of the other articles. Overall, all the articles plus the textbook were able to explain the patient in the case study, the 38-year-old attorney, when with her complaint of tiredness, difficulty concentrating on her work, having that decrease in memory, and just her decrease in frequency of bowel movements, her a difficulty avoiding gaining weight, and how she's having chills even though she's got a light sweater on, and that she's losing some of the like hair and it's coming more like fine, and that she showed a moderately enlarged thyroid gland even though it was non painful. It was painless. Also, with her laboratories showing that her TSH was elevated, and how the anti-thyroid globulin antibodies was positive, and the antimicrosomal antibodies are positive, also is an indicator of Hashimoto thyroiditis, as well as when they did the final aspiration of the thyroid gland, they revealed lymphocytes, plasma cells, and clusters of enlarged follicular cells that had contained like Hirth cells, which is also an indicator of Hashimoto thyroiditis. Hope you guys enjoyed this case study and the articles. Thank you.